This is Dr. Ban with DocTalk. Today, I'm bringing back my favorite physician cardiologist, Dr. Subh Agarwal, because we want to talk about the heart and the cardiovascular system. It's one of the leading cause of death in our country. And prior to the pandemic, this is the biggest part that we're concerned, whether in my primary care setting, whether it's in my urgent care, or in the ER. That's one thing that we do not want to miss as a physician. And so what had happened to all the patients that normally come into the hospital with heart attack, some kind of cardiovascular disease that we have to think about. And so I got a paper sent to me by my sister talking about somebody had a heart attack, they go in, it's from infection from COVID, and the heart exploded. Well, these are all things that are, to us physicians, are not really what happened. But I want to take you through the incident and get you from somebody who's an expert in the field and tell you what happened during what happened in heart disease and cardiovascular disease, and then what happened during COVID. But before that, I want to share with you, Dr. Agarwal and I have actually spoken this morning, and I want you to get an appreciation. You know, the man is in his suit. He hadn't been asleep. He actually came back. It's what time is it your time? About 12 noon your time. And
Yes.
he's been awake working the whole day. He have not been asleep. So can you tell me what it means to be a cardiologist and what your day is like, and especially when you're on call this whole weekend? Because I want people to appreciate what it feels like to be a physician and especially a cardiologist.
Well, Bon, thank you so much for inviting me back to your podcast and for your always these nice presentations and kind introductions. So, I mean, these are tough times, these are challenging times, and we are coping with this. But you asked a very pertinent question regarding almost all physicians are working hard, including nurses and pharmacists, especially, but in cardiovascular medicine, we are working twice as hard. Although our procedural volumes have gone down, we are getting a lot of consultations because of the COVID-19 disease. And also then we have other patients who are still presenting to us with non-COVID-19 related cardiovascular issues. So I was on call this weekend, as I was telling you, and it was one busy weekend. And I was hoping to get some sleep today. But boy, the pages did not stop all night, and we have some really sick patients who need some procedures performed today. So it was tough managing those patients through the night, and this has been going on for 3 days.
Mm-hmm.
But here I am. I took I took a ice cold shower because I really believe in that. Did my meditation, whatever I tell in my workshops, did my breathing exercises, and I'm ready for your podcast.
Yeah, thank you. I know you're tired. I'm trying to get you to be able to go to sleep because I've been on call many moons ago, and it's hard. You need people to help you, but when you interrupt somebody's REM sleep and you're on not only a whole day, but you're on that nighttime, it's really hard. And I can see it in you how tired and mentally it's fatigued to you. And it takes a few days to get the body back used to your regular circadian rhythm. So, I want you to get to sleep soon, but, I want to thank you and appreciate everything you do, because it takes a lot of work being a physician, especially when you're a specialist and there's only one of you to cover your group and a whole hospital call you. Is hard on the body. But let's talk about this, okay? So one of my biggest fear, and it's been ingrained in me as an emergency physician, is that you do not want, so we have a emergency physician who's also an attorney. So the one thing he ingrained to us, and we both were trained by the same one, is don't miss a heart attack, right?
Correct.
And you miss that, most likely you're going to be in trouble. Most likely you're going to be sued. But the worst outcome is that people are going to die from it. And so in this case, talk me through like some what causes people to have let's keep it simple, right? Just what causes people to have a heart attack, give me some ideas, and or just the people to understand a little bit.
So, it's a simple question, but,
Mm-hmm.
it is a little bit worded,
Mm-hmm.
complicated answer. Because I think that now we are understanding this. We did not have an understanding many, many years ago, but I think with long-term cohort studies, and the one which comes to mind, which everyone is now familiar with, is the Framingham Heart Study. But there are multiple studies. There is the multi-ethnic study of atherosclerosis.
Mm-hmm.
There's a study called REGARDS, which is capturing the southeast area. There's ERIC, which is atherosclerosis risk in communities. So what they have taught us that we should start paying attention to modifiable and non-modifiable risk factors. So when I say modifiable, such as smoking, that's a modifiable risk factor, or sedentary lifestyle, physical inactivity, obesity, high blood pressure, high cholesterol, to name a few. And then some non-modifiables, it could be your age or, our genetics. So those are non-modifiable. There's environmental insults. So over time, not right away, but over time, this can lead to what we know now is hardening of the arteries, which supply blood to our heart muscle. Heart is a muscle, and it is rich in, it has a microvasculature of its own, but we are focused on the three main arteries, the epicardial arteries, which we call, and they can get clogged. So it's a plumbing disease. So when it gets clogged, there is decreased blood flow to that part of the heart muscle. And the way the body reacts to that is in form of pain. So someone comes to the emergency room, which you and me used to treat,
Mm-hmm.
and they will say, okay, I'm feeling discomfort. Or they may feel short of breath. So these are vague symptoms. Or they may say, I'm fatigued or tired. So that's one presentation. I mean, there is a myriad of presentations. So they could come with something we call an acute heart attack, which could show up on the ECG, which you and me do right away. And we call that either ST elevation or non-ST elevation, unstable angina. So these are basically telling us that the patient is suffering from myocardial necrosis.
Mm-hmm.
They could present with collapse of their function. So we call that cardiac dysfunction, cardiogenic shock, circulatory collapse. So the blood pressure could be low. This phenomenon is seen, in postmenopausal women, where they could have stress from, loss of some very close relative, loss of job, some kind of stress, divorce, a lot of work. We talked about work, that can lead to stress cardiomyopathy or Takotsubo cardiomyopathy, inflammation of the heart from infections. So in the developing world, we are dealing with, let's say, tuberculosis. But here in the westernized world, we are dealing with viral infections. So any viral infection, influenza, or Coxsackie, Epstein-Barr virus, they can not just cause pneumonia or an upper respiratory infection, but they can also directly infect the heart and cause a viral cardiomyopathy down the line.
Mm-hmm.
Pregnancy has a stress on the heart, and some unfortunate ladies can develop postpartum cardiomyopathy. There are so many genetic disorders, hypertrophic cardiomyopathy, restrictive cardiomyopathy, infiltrative disorders of the heart. Here we are dealing with COVID-19, so that can also infect the heart directly, and that can cause cardiomyopathy. You could have arrhythmias of the heart. As you know, this is not just a muscle with pumping action and coronary flow, but also it's an electrical pump. So the conduction system of the heart can become deranged, either because of mutation or genetic disorders, and can lead to arrhythmias. over time, ischemia of the heart can cause atrial fibrillation, or young people can get SVTs. You could develop non-ischemic cardiomyopathy, this drug use, cocaine, all these things. So the presentation of heart disease is multiple.
Yeah. So just sort of a quick summary. So in this case, we talked about it being almost like a plumbing injury, right? So you got blockage in the area, the blood flow is decreased to the heart muscle, and it doesn't get the nutrients, the oxygen that it needs. It dies. The area is one that electrical conduction is impaired, can potentially lead to somebody having an arrhythmia where the heart doesn't pump. It's the cells are become very erratic. It doesn't pump. Blood flow doesn't go around. It doesn't circulate to the brain, to the rest of your body, and person can die from it. So a lot of times that's sort of the simplistic way of looking at heart attack. So that's what the main thing we've always been concerned with, and time is of essence because we want to replenish the flow of blood, replenish the area of the heart tissue so it doesn't die, causing the arrhythmia. So what's so unique about COVID now that we have an isolated group of people that you see more than you would not have? So what do you see in patients that whether they already maybe have existing cardiovascular injury, now they have to deal with something of the stress which you related to is this really bad virus?
So unfortunately, whatever I just said, we are dealing with the non-COVID-19 cardiovascular disease epidemic. We have almost 50,000 deaths every day from this continual pandemic of cardiovascular disease since 1918. It's the number one killer. 50,000 deaths every day all over the world. So that's every 2 seconds. And then in the US, there's one cardiovascular death every 40 seconds. So whatever I just listed are some of the presentations. Unfortunately, some of these presentations are also seen even with COVID-19. So COVID-19 can present with an ST elevation myocardial infarction. So the patient comes with chest discomfort. You will see ST changes, and you will activate the cath lab appropriately. You will say, okay, this patient is having chest discomfort. The cardiac biomarkers are elevated. There's EKG changes, and we take it into the cath lab. And we find that 50% of these patients have non-obstructive disease. So they present with STEMI, but 50% are non-obstructive. So it's possible that they have myocarditis and they are presenting with STEMI. So, I was on call this weekend. I had all these kind of cases, and I can show you some of the, we can go through some cases after this to show you and bring the perspective to the patient that what we are dealing with. They could present with arrhythmias. In fact, I had a patient who actually presented with ventricular tachycardia. So they could just have coronary vasospasm. But I think the main thing is that they're also having concomitant lung disease. So they are having pneumonia, and also they have heart failure. So they have cardiomyopathy, they have myocarditis, they could have injury to the heart, and additionally they have pneumonia. So these are the presentation, and arrhythmias. So someone with non-sustained or sustained ventricular tachycardia. So these are the presentations we are seeing currently in our system right now.
So that's a very interesting thought. So I'll go back and sort of summarize for somebody like myself to an ER doc to understand a little bit more. So usually what will happen is a person can present to the hospital with symptom of having a heart attack, some blockage in the area, and we want to take him to the cath lab. What Dr. Agarwal is talking about is to be able to run the wire up there to see what area is being blocked in the heart, and then we want to open up those areas so we get the blood flow right away, and time is of essence. So what you're saying now is that there's so many different things that even though the presentation sounds like a blockage, when you come in there, it's actually not necessary that way. Only 50% of those are actually blockage. the other one are actually are not. So that's what the confusion that we see is that what we see on the EKG, what we normally think a blockage, are not really necessary. You're injuring the area of the heart that looks like that on the EKG, but it's not necessarily what you find when you show up to the cath lab. And so in this particular case, if do you think there's a certain age group that you see more that present with this presentation?
So, I think I was under the impression that it is affecting mostly elderly males, and that's still the majority of cases. Thankfully, I mean, not for them, but for others. But the two cases I can show you today in our discussion, they were young people. One was a 55-year-old lady, and the second guy is a 40-year-old male. So we are still seeing these cardiovascular manifestations, even in a middle age group, not just in the old, but that's the scary part, that we are seeing that even in the middle age group. And those who are having pre-existing disease, cardiovascular disease, obviously their presentations are more. But we are also seeing de novo heart failures. So with COVID-19 disease, series of studies, like there was a 21 series study which shows that 30% had new onset heart failure. So we are seeing, even in the younger population, these presentations and new heart disease in this patient population, even if they did not have underlying heart disease. And I think that it could be that we think they are healthy, but they're not. So like when the ER calls me, they say, hey, I have a 40-year-old who has presented with heart failure. And you check for COVID-19 and it comes back positive. But when you really look at the profile of the individual, he's a 40-year-old, agreed, but perhaps has not seen a physician for a while, and has made daily trips to Portillo's and McDonald's, and the BMI is 45. Mm. So, in my opinion, that is disease. The patient has underlying risk factor for heart disease, and now it's manifesting as heart failure, but in the presence of COVID-19, there was acceleration of that process. Does that make sense?
No, it makes a lot of sense. It's just because you don't go to your physician, it doesn't mean you're healthy. And so in this particular case, and when you tell me that, it reminded me of a case that I saw on a patient that was about the same age, in the mid-40s, no medical history. And this is the case I thought I present as maybe a reactivation, because he was doing, he had some symptom that it sounded like COVID for about 2 weeks. Now he's going on the third week. He thought he was getting better. And then all of a sudden he was just hit like, wow, I just don't feel well again, start having some chill, body ache, and start developing shortness of breath. So went to the hospital, his oxygen started to drop, and then they end up intubating him. And during the whole process, he started having to sound like to them like a heart attack. So they took him to the cath lab and went through, and they didn't see an occlusion of the artery. But then when they came out, they sent him home saying he had a heart attack, and then they gone through the same pathways. And what I think is happening, what you said is correct, is that people have underlying issue, right? And that's what is shown in our country. We're not really healthy. And if you were talking about over 70-some% of male are either overweight or obese, that's not healthy, right? There's something wrong. If we're talking about 50% of people are pre-diabetic or diabetic, that's not really healthy, right? So that's when you start lumping that in 330-something million people, that's a lot of people that you worry about. So I think having a stress, right? We always talk about what's the stress that causes that this to show itself. In this case, happened to be a stress that we never seen a novel virus like this that damaged multiple different organs, so from the lungs to the heart. And so it makes perfect sense to me to see that when you're assessing the people, they're not actually healthy. You know what I mean? And you break it down, they're not. How about if you break down some cases for us to see what it's like on a young person? Because I'm start seeing cases that in young people, supposedly no medical issue, but have stroke. So I don't see why it would limit to the heart, because we have blood vessels that feed a lot of different organs. So why would not affect the brain for stroke? And why would only limit ourselves to injury to the heart? Why wouldn't it injure the kidney? Why wouldn't it injure the liver, the lungs, etc.? So help us through some of the cases, because I really wanted to see and understand what does it do, because the body is a whole, right? We try to we try to understand and isolate it, but if you put it together, it would make perfect sense to most of us.
Right. I mean, we can talk about the mechanisms which we are trying to unravel. It's
Mm-hmm.
not clear, as you know, about the mechanism, but I think we are trying to unravel, and I think I will show you some slides where we are, I think, in the process of understanding some of these diseases. But let me actually share with you some of the patients I actually saw this weekend. Actually, I was on call,
Oh yeah, that
and
would be great. Yeah.
let me show you a patient who presented to me to us this weekend. So let's see. Here you go. So if you can see, this was a 45-year-old female and pretty healthy lady. She her only issue was having some high cholesterol, and she was on medications, well controlled, and she presented with chest discomfort. And although subtle, I give credit to the emergency room physician. He immediately took the EKG. And with my pointer, I'll show you that you can see some ST changes in lead 1, as you can see. And then also you can see some subtle ST elevation in AVL. So he called us and said that, listen, I think I have someone with a high lateral infarct. So normally someone with a diagonal or a circumflex artery infarct. And I looked at that EKG. She did have one risk factor. So we took her to the lab, saying that this was acute STEMI. So this is what it looked like. And now it looks much more ominous.
Mm.
You can see the deep ST changes on lead one. You can see the reciprocal changes, which is confirmatory for MI. And then you also see these ominous changes in the anterior lead. So there's almost like a diffuse ST elevation.
Mm-hmm.
So we thought that, boy, this is a left main disease.
Yeah.
This is a tough condition here.
Yeah. It's so weird on a young woman too to see.
Right. Very young lady. And we took her to the cath lab, and we thought that this is left main disease or proximal LAD disease. So just to show you, this is a catheter you can see at the top left corner. And I'm injecting dye into the artery. And this is the left main. You can see the left main artery there. And then you can see the left anterior descending, going all the way down. So this is where we were suspecting disease. And this is a large circumflex artery coming out. The right coronary artery was injected. It was clear. But basically what we saw was there was almost no disease here.
Yeah.
You know, she may have had some thrombus in the diagonal, we thought, to cause the ST change initially in the one in AVL. But also, if you looked at the prior EKG, she had atrial fibrillation on that EKG with ST changes. So we thought that perhaps she had paroxysmal atrial fibrillation and developed thrombus, and that thrombus may have, moved and gone into the circulation and somehow entered the coronary circulation and caused the infarct. So that was the theory we had. But I was surprised that she did not have any coronary disease, and she came back positive for, COVID-19.
Wow,
so this is the presentation.
Yeah, her artery looks so clean. I mean, it's well
pristine.
Yeah.
It's pristine,
Yeah.
So I mean, imagine this is the presentation. So this is stress, we are taking her to the cath lab.
Yeah.
She comes in, she has this presentation. But I wanted to show you what is most surprising. So now I wanted to explain that why the EKG changes, which you saw, right?
Mm-hmm.
So now at this point, we stop and we got ultrasound of the heart, all right? Mm-hmm. So let me show you. Let's see if I can play this for you. So this is the ultrasound of the echocardiogram of the heart. And this is a non-contrast image. And you can see that this is the left ventricle. This is the major pumping chamber of the heart. So you can see that this muscle here is thickening. Can you
Yeah.
see that?
Hmm.
But you see that there's a hinge point and you don't see this wall moving at all. So that is what we call an infarct or myocardial necrosis. So let me take you to the next one. And this is an echocardiogram which has been done with contrast to understand the muscle and define it better, understand it better. So now you can clearly see that the basal segments are moving, but the rest of the heart, this is non-moving here. And we call that akinesis, meaning no movement of the heart at all. There could be some hypokinesis here. So I took multiple pictures to clearly show that only the basal segments are moving, the rest of the heart is not. And you saw the angiogram is normal,
Yeah.
correct?
Incredible.
It's an incredible image. See a dilated heart. So this is new heart failure in a patient who has no coronary disease. So again, this confirms that, there was a paper from Dr. Bangalore. He is a prominent interventional cardiologist in New York. And he came out with this series of 19 patients published in New England Journal of Medicine, looking at 19 patients who had COVID-19 and presented with a STEMI, a ST elevation heart attack,
Hmm.
and took them to the cath lab. 50% were normal. So I think our patient fits that profile, that she had a normal coronaries, but she had this cardiomyopathy. And so the worry is that we thought this is Takotsubo, stress cardiomyopathy,
Yeah.
but this could also be myocarditis, which is
Hmm.
direct infection of the heart from the COVID-19 virus, leading to failure of the heart muscle. So
Yeah.
significant ST depression. She was in heart failure. Uh, Luckily, she's doing well. We have her on good medications, and she's doing well at this time. We did not do a biopsy of her heart. We have her on good medicines. I'm hoping that she will improve. We did end up getting a cardiac MRI on her. So
Do
you
you
can
know?
imagine that so many resources. I mean, you could imagine how busy we were dealing with just one patient. I'm just giving an example of one patient here.
Do you know what, like, how long her presentation were, like, of her symptom before she came into the hospital?
So she said that this started early in the morning,
Yeah.
and and uh, and she came to us. She said it started at around 10 in the morning, and she was seen by us right away. So that's what I think is a worrisome feature
Yeah. What
for
is
this
sort of
patient.
scary to me is that so many patient presents, like, when we talk about it, how they have pressure in their chest and
Mhm.
can't breathe. And imagine, like, if you have that presentation in somebody who's in the 50s, 60s, 70s, and I see it all the time, even in the 40s, you would say,
Right.
well, you better go to the ER. But look how many people are at home dealing with this. And to me, that's, and people worry about coming to the hospital. And, we can talk about the fear of people going to hospital, but I mean, this case to me is extraordinary because it makes you really wonder what's happening to people when they go through this.
Right. So is this projecting onto you?
Oh, yes, yes.
Okay. So this is and the patient I saw, and again you can see it's a pretty young guy, 40-year-old, and this gentleman presented with this rhythm
Yeah.
to the emergency room. So you can imagine the call I'm getting from the ER, and we shocked this patient,
Hmm.
and this patient had ventricular tachycardia. This is what is VT.
Hmm.
So you can see again, we don't have to become that technical, but if someone is watching and has medical background, you can see that there's positive concordance across the precordial leads. And it's very symmetrical. So you don't see any irregular intervals. And they almost have similar morphologies. And we could this QRS morphology, you can see it looks different from this morphology. So I think this is almost like a fusion beat, you can see. And I could not, I was trying to look for AV dissociation, and there could be some AV dissociation going on, but not very clear. But clearly this is ventricular tachycardia. And we ended up performing a cardioversion on this patient, synchronized cardioversion, and it worked. But you can imagine that these are the kind of patients we are seeing right now in the COVID-19 pandemic. So I thought this was a pretty interesting presentation.
So after you cardiovert this person, meaning putting back, so just help everybody to understand that you do that, you put them back in the rhythm that allow the heart to beat at the regular synchronized beat. So it's set by its own pacemaker at more of a steady pace. What was the rate on that one again?
This one is, I can tell you, is around 270.
270?
Correct.
Yeah. So you imagine
240. It's 240, I think. 240.
Yeah.
I'm sorry.
So you can imagine what a normal heartbeat. So mine usually in probably mid 50s and maybe low 60s, right? But as you'll see, is that most of us are not running at 200 something, even for a 40-year-old. That's a pretty fast beat, and no way the heart's gonna be able to pump blood and be able to function properly. Yeah, that's an incredible case. That's also COVID too.
Can you hold for 1 second?
Oh, sure.
Ban.
Yeah, that's an incredible case. So that case was that. What's the presentation on that young man like?
Yeah, so this gentleman he's young guy, and suddenly he starts feeling that his heart is racing, and he felt dizzy and not well, and he presents to the ER. Now, this guy has a prior history of atrial fibrillation, and was seen a year ago. So he is on antiarrhythmic medication, but that's about it, and no other history. And I looked at his echocardiogram, which was just done 6 months ago, the ultrasound of the heart, and it was completely normal. So it threw a curveball at me, because now you have someone who has a normal ejection fraction and has a known history of atrial fibrillation and is on medications, and suddenly presents in ventricular tachycardia out of the blue, and tested positive for COVID-19. So that's what we are seeing. They are presenting with a myriad presentation, different kind of presentations. So, we are seeing these presentations in our daily lives when COVID-19 was not there, but we knew the mechanisms. It probably was drug related, that the patient started having one-to-one conduction and went into ventricular flutter. So we are seeing those presentations, but this one has completely thrown us off. So although we have that in our radar, but we have to have our antennas up now with COVID-19. So I think these two cases were the highlights of my weekend, actually.
Yeah, what make me really concerned is the fact that we tell a lot of our patients just go ahead and stay home and sort of not do anything. And so if you see these two cases are fairly young people in their 40s with not a lot of medical issue, but really has some bad pathology. One is a lady have good blood flow to her artery, but have damage to the muscle wall, cardiomyopathy. You can see that on your echo. And then the second young man has history of some atrial fibrillation, meaning there's a site that's highly excited, but you're on medication, control that. And then come in with COVID, but really arrhythmia that can kill him, right? In this one, without any type of, presentation of illness that's severe. So I'm not trying to scare people, but I want to say that we have to be very careful how we phrase things and get people to do certain recommendations, stay home, etc. But it's also got to be mindful that is to tell people like their time when you really need to go to their doctor, go to talk to a professional, go to the hospital, because there's certain what you have shown me really can lead to death, and especially young people.
Yes.
Absolutely. So, you're bang on that. And I just wanted to, if you will allow me to discuss that why we are seeing these things, I think we are able to tie these things together now. And I think we still don't know the exact mechanisms, but I think we're understanding something about the heart and SARS coronavirus 2 infection. So you know that COVID-19, and you have talked about this so much in your podcast, that it is associated with a profound systemic inflammatory response. And the cytokines, the inflammatory cytokines, in particular, TNF alpha, which is the tumor necrosis factor alpha, IL-6, like on this slide here, the interleukin 6, interleukin 1 beta, they directly suppress the cardiomyocyte function and cause depression. And we saw two examples of that. We saw the first lady, she had cardiomyopathy, so she had decreased LV function. She had diminished LV function. And then you see a person who presents with ventricular tachycardia. So one mechanism we think is the inflammation leading to cardiomyocyte dysfunction and cardiac depression. So that's one mechanism. So it can directly cause myocardial injury leading to these kind of presentations. It can also cause sympathetic hyperactivity. In one of our podcasts, when we talked about drugs causing QT prolongation, we talked about drugs such as macrolides, fluoroquinolones, psychotropic agents. They all are hERG channel blockers, which acts on the phase 2 of the cardiac action potential. Similarly, IL-6 does the same thing. It blocks that phase 2 of the action potential and lead to QT prolongation. Additionally, imagine that they're sick, they have a cytokine storm, the IL-6 is causing all these injury patterns, and we are giving them medications to treat them. So it becomes a perfect storm. And, we talked about why they have VT. So I'm just trying to show you that this is one proposed mechanism. And I borrowed this slide from Lazzarini, which was published recently in Circulation this year. Mm-hmm. So the other proposed mechanism is that the SARS coronavirus 2 can directly infect the heart, just like any virus. We talked about viral cardiomyopathies, mm-hmm. and it can directly inflame the heart and cause myocarditis. And we have shown that with ECG changes and MRIs, which show us that there's inflammation of the heart muscle. And if you remember the SARS coronavirus 1, mm-hmm. we were able to perform autopsies on these patients. And studies have shown that 35% of the hearts were infected with the viral RNA. So there's a large amount of infection of the heart. And the third is that this, as you have talked about in the beginning, that the ACE2 receptor is present in the blood system. It's on the in the vasculature. So the SARS coronavirus 2 can impact the microvasculature, and that can lead to cardiac dysfunction, tissue ischemia, which can cause stroke, kidney disease, and it can cause ventricular dysfunction and arrhythmias. So I think I just wanted to present this slide so folks can better understand that what are the possible mechanisms. We are not even sure of all the mechanisms, but these are some theories which I think make sense.
It's really extraordinary, but it's also a little bit scary how much interaction, so many different tissue that the virus can affect. And the sooner it's not surprising to me when people tell me how they feel, especially they're going on 7-10 days of the infection and how bad they feel. And the common one that I always hear, not just cough, trouble breathing, chest pressure, but just a weakness. And the amount of weakness people have is extraordinary. Where I follow, and on the previous podcast, I talked to the pastor and his family. It's extraordinary to me that after the treatment and after he feel like he can breathe, it took him a month to actually come back to feel like it's normal. That's extraordinary for, and like I said, he's not, he's probably in mid-50s, doesn't really have any lot of medical issue that he knows, right? And that could be in subjective and in a lot of ways, but still, he's in his 50s. For him not to be able to get that feeling of weakness to fully become what he feel is where back to his baseline was more than a month. It was incredible, to see that. So in this case, you seen the cases, you made your diagnostic for these patients, have an idea what the mechanism, and so tell us a little bit more about the prognosis and what's the strategy for treating the patient. Because now you have teased me enough where I'm like, come on, you got to show me now because I'm drooling. I'm trying to understand now.
So I think that's a great question. So we are good now in detection. So our antennas are up. We are prepared that we now know that it can present in multiple ways. And you may not just have a plain STEMI, a heart attack, but it could be, COVID-19. You may not have just an arrhythmia, but so we are checking our patients for that condition. So I think we are understanding that. What we have at our disposal now, and I think this is a very important point I want to make, that absolutely any person who presenting to the ER with any inkling of heart disease should get an ECG. Mm-hmm. And the second thing is that if they have been diagnosed with COVID-19, even if they do not have heart disease or they are not complaining of chest pain, we should be able to risk stratify them. So if they have been made, the diagnosis of COVID-19 has been made in the hospital, I'm talking about, not in the outpatient setting. Because again, we know a majority of them, thankfully, that's what we think, will not have this grave of disease and they will sail through. But 20% of them will have. So I think that we do have some very important tools at our disposal. And I learned them over the past month dealing with this pandemic in the hospital. From the cardiovascular point of view, I'm using high sensitivity troponin and the BNP, the brain natriuretic peptides. We are using CRP. We are using ferritin. We are using LDH. So I think these are really helping us in prognosis. So that's what I wanted to talk to you about, that perhaps we should never have looked at troponin as just as diagnostic tool. Mm-hmm. You do a troponin in the ED and it's minimally elevated and we think they're having an ACS, and you end up calling one of the cardiologists thinking that, oh, should I start this patient heparin? So it's not true that every troponin rise will be, acute coronary syndrome. So I think that's what I learned. And it can help us, give us a great prognosis. So I was just going through that data, and I found that absolutely we need to get troponin. And let me actually show you this slide, which I have on troponin, so it will become more clear that what we are dealing with. So let's see, let's share. And so now you can look at these slides, that how complicated this structure is. So basically, when we talk of troponin, this is a complex protein molecule, which is a combination of three components, the I, C, and T. And it is in a combination with tropomyosin and actin and all these filaments, and they're involved in myocardial contractility. So when there is a...
So this is, just to have our viewer understand, this is an isolation of a muscle, okay? That's what Dr. Agarwal is talking about?
right? This is the
Let's talk about
cardiac
the
heart map.
muscle and the troponins or complexes of that muscle allowed to contract and relax so that the muscle will then, so he's talking about the heart muscle at this particular point.
Correct. So you and me have discussed this when there is electrical flow in a cardiac muscle, and you call that an action potential depolarization. What it does is that it leads to increased calcium inside the cell. So here we are talking of the heart cell, the heart muscle cell. And so there's diffusion of the calcium inside the cell. And there's also release of calcium through a structure called the sarcoplasmic reticulum, if you want to go in the molecular details. And that calcium binds to this component, the troponin C. That's why it's called C. It binds to calcium. And through various complex mechanisms, if you can see these dark, thick lines and these thin lines, they converge towards each other. So this is what we call contraction. It shortens. So that's what we call muscle contraction. And then when they separate, we call that relaxation. So basically, these are just regulatory proteins which are involved in the interaction for actin and myosin through various mechanisms. We don't even understand this wholly, by the way. There have been research going on for 50 years. So when there is damage to the cell, the myocardial cell, and by the way, these are specific for the heart. So there are some isoforms. They have isoforms which are controlled by genes, which are present in skeletal muscles. But these are specific cardiac troponins. So they're specific for the heart. And when there is death of heart muscle, then these break down and they're released into our blood. And then, when you go to your doctor in the emergency room and they check for these enzymes, their assays, they do, their antibodies which detect the level of these troponin complexes. So normally either troponin T or troponin I. And if they're elevated, that tells us that, okay, this patient may be having a heart attack. There is damage. So what are the reasons for cardiac troponin to go up? And that's what we are talking about. Mm-hmm. So you and me in the ED are very much concerned about a heart attack. We don't want to send that patient home. So that is primary cardiac injury. So myocardial heart attack, infarction, necrosis, that can lead to direct rise of troponin. But also now we know that not just it's a diagnostic tool, it's also a prognostic tool. Mm-hmm. So secondary ischemic injury, secondary injury to the heart can happen from what? You put a stent. You will cause damage to the heart muscle during the stenting procedure. You do an ablation. You're burning the heart tissue. So you're causing death of the heart tissue. And the troponin will go up. In fact, I got a consult, not this weekend, but a few months ago, where a patient had ablation and was admitted to the hospital for some reason. And they called me because the troponin was elevated, but the patient was not having any chest pain. Mm-hmm. So that is an indication of secondary ischemic injury. Blood clot to the lungs will cause rise of troponin. Heart failure will cause troponin rise. And then there could be non-ischemic insults to the heart. So the heart is not involved, but something else is going on. So you see that commonly with sepsis, pneumonia. You'll see a rise of troponin. So trauma to the heart, let's say someone punches someone and they get hurt, that can cause contusion and can cause troponin rise. Patients with cancer getting chemotherapy, renal failure, we see that a lot. Patients with kidney disease, they will have a rise of troponin. So it creates a dilemma for the emergency room physician, for the cardiologist, for other physicians involved in the care of this patient. Not every patient needs to go to the cath lab. Mm-hmm. Not every patient needs to be on thrombolytic therapy or antiplatelet therapy. So I think it is amazing that we have this tool to diagnose But I think it is an invaluable step forward. I think that's how I approach it.
Mm-hmm.
In identification of high-risk patients. So it can be a great prognostic tool in identification of high-risk patients. So if you will allow, the other marker is a BNP, the natriuretic peptides, similar to the troponin complex. And if someone has COVID-19, since we are talking about COVID-19, so someone has COVID-19 and has cardiovascular disease, and the troponin is up, the mortality of that person can be as high as 70%. Almost an unacceptable number, but that's what you and me need to know.
Mm-hmm.
That they have COVID-19, they have prior heart disease, and they have elevated biomarkers. So not necessarily troponin, it could be BNP. Their mortality is as high as 70%.
Wow.
Someone who has COVID-19 does not have prior heart disease, but their troponin is up, does not mean that they're having a heart attack. It tells me that this is a high-risk individual, and their mortality is as high as 40%, 40. Someone who has COVID-19, whether they have heart disease prior to or not, but their troponin is normal, they are, high risk, but they are much lower than someone whose troponin is up. Their mortality is 5 to 10%. Look at the difference. 5% versus 70%. So I think that's what I'm looking at it now, that not only this is a diagnostic tool today, it was always a prognostic tool, but I think we're applying it better in this pandemic.
Yeah, I appreciate it. Can you take down the slide so I can see you for a second?
Okay. Let's see, how do I stop sharing?
Just stop the share.
Okay.
But that's a very, very good point, because as an emergency physician, we always look at troponin and its only relation to the heart. But what you brought up, a very important part, is that there's so many different variable, and especially different muscle that can release these troponins. So it makes sense that people with, stress, right? So stress and injury is what you're seeing in an individual. And from that, you can see why the damage releases these troponin, and it's used at more like a diagnostic is one place, but you can make a prognostic indicator as well. And I love that, because somebody who you've gone and you see with their troponin being so much lower, you can rest assured that their prognosis is a lot better. Than you have to be mindful of somebody who have shown to be more in your category 40% or 70%. Their risk of death is a lot higher. So you have to be more aware, and that you cannot just focus on one organ. I think that the message I got here is that the body works together, and all these interaction, all these different organs is what you're trying to assess from this patient, more so than just looking at one thing. But that's really genius, I think, of how you'll be able to put this together, even though your focus was more what they're asking for, the cardiovascular, but you're also to be able to see that, look, if you see that in this area, why wouldn't you see it in the liver, in the kidney, the lung, the brain, etc.?
Yeah, I mean, you're right. I mean, we have to look at everything holistically,
Mm-hmm.
So you and me are familiar with the pneumonia severity score index, right?
Mm-hmm.
You decide whether you want to send this patient home, or you want to observe this patient in the hospital, and you decide whether you want to give oral medications or you want to give IV medications. So you put in some variables, right? You are putting in the blood pressure, let's say, or their oxygen levels, all those kind of things you are putting in together. And that is what gives you the pneumonia severity index. I think what I've learned over the years, and we get called, by the way, the troponin is up. Should I start them on heparin? No. I think we forgot to add that to the pneumonia severity index, because it tells you that, okay, this is a high-risk individual. you should not just send this patient home. Same thing I apply for PE. If you have pulmonary embolism in the ED, you do a BNP, D-dimer, and a troponin. And these are markers, which tells us that this is a high-risk individual. You better heparinize them and observe them for a day or two before you send them home. So I think that's what it is. It's just a prognosticator.
Yeah. So what will be our treatment strategies?
So, multiple individuals are involved in the care of these individuals. They will be on the usual medications from the heart point of view. So definitely I'm going to start them on aspirin.
A 325, or we're talking about baby aspirin like 81 milligrams?
Right. So normally they are getting a high dose aspirin when they come to the ED, 325. But now more and more studies are showing that 81 milligrams does the job. So we are in the US, in Europe, they do 100 milligrams. In the US, we are doing 81 milligrams, and it is enough to cause platelet dysfunction. It's an antiplatelet, so it's enough. Then we are starting them on neurohormonal agents, such as beta blockers. So we talked about Lopressor or carvedilol. If they're decompensated, then initial therapy would be water pills. So diuresis, I want to decongest them. So once they become dry, then to blunt their sympathetic response, I will start them on beta blockers. So carvedilol, Lopressor. And then I will blunt their RAS system by introduction of drugs like enalapril, lisinopril, Entresto now is the new kid in the block. We have known from trials such as RALS that introduction of mineralocorticoid blockers such as aldactone, eplerenone improves survival by 17 to 20%. So we'll introduce that in the armamentarium. So that's from the cardiovascular point of view. Mm-hmm. But when you have COVID-19, obviously we are in our hospital, we are using hydroxychloroquine. We are using antibiotics, so Zithromax. We are carefully monitoring their QT intervals because we know that they're having cytokine storm. We know that these drugs will prolong the QT interval. So if they have a prolonged QT, unfortunately, they cannot get the drug. Although we don't have randomized data, we have some studies which show there could be some benefits, so we are using that. We are using IL-6 blockers like tocilizumab, and we are also giving remdesivir. We are doing convalescent sera. In our ICU, we have the plasma, so we're using that. And we have one or two patients where we have actually done ECMO. Mm-hmm. And we have had great success in managing our patients. Our ICU mortality rates are very low at 10%. We have had huge success. So kudos to our critical care intensivists and nurses. They're doing a phenomenal job.
Yeah, that's, today, thanks for being here today, because it's so important. I think you bring up a lot of important and key factor that we haven't really looked at is I hear it all the time, like what will happen with the pandemic and what are the consequences of people being infected. We only see in short term, because that's all we have data for, is what happened to the patient now, they recover and everybody goes on. But I have a feeling that we really will have side effect from the infection, from the cardiovascular. And to me, it's a lot of things that is really inflammatory response that's going to lead to a lot of these things. So, from blood pressure, cardiovascular disease, other heart disease, stroke, talking about diabetes, all these things that all link together, we're going to see more of that. So I think what we should really try to focus is not, right now I know the mind is always focused on COVID, but I think what it opened my mind is more and more is that what we've been pushing this for a long time is how do we take care of health, because we basically have been exposed ourselves that we are not a really healthy society. And having seen this is really show me the stress that something put in your body really expose your weakness, and that's our weakness. We have a lot of health issue in this country.
I mean, you are right, absolutely bang on. So right now, when I say success, it's in terms of saving lives. But okay, in my watch, patient survived the coronavirus. But still, that 50-year-old female and that 40-year-old guy have a lot to deal with. Think about that. She was just on high cholesterol medicine. Now she has a heart function of 20%. You saw the heart. It's ballooned. It's not working. She lived today, but now she has to deal with the consequences of this disease process. Same thing with the other guy. He's 40 years old. He has a long life to live. So I think I'm worried from that point of view. We have data, there is a large term data gathering going on called Interheart study. And we have learned a lot from those big studies. And this is a global study where they are looking at what factors are involved in giving us good cardiovascular health. And when they applied those parameters, that, okay, these are the 6 things you need. So you should be active, you should not be smoking, you should be eating right. So all those 6 parameters, how many people in this country, in the US I'm talking about, actually have all those 6 parameters? You'll be surprised, only 3% fit the bill. So we have 97% of the population who is not fit. And that is something which is an opportunity, I think, for both you and me to work on. I can tell you that these 2 patients I talked to, they were like, you know what, doc, whatever it takes, I'm willing to do to become healthy. And that's good. That's great that they want to do that. And I will use my resources and I'll teach them to get better. But what I'm trying to hope is that through your podcast, people will get the message that, listen, we need to intervene earlier.
Yeah.
And it doesn't cost much. Prevention is still 100 times, in my opinion, better than cure. I mean, it's expensive, it's time consuming, it is emotionally, disastrous for the patient. Unnecessarily people are dying when they don't need to. So I think if we can intervene earlier, if people can become healthier, then I think we'll have much, much better outcomes.
Yeah. Yeah, I want to thank you for today. And I think it opened my eyes quite a bit and I learned quite a bit. And I'm glad you didn't quiz me on the EKG. So I appreciate that. Cardiologists love to quiz the ER guy. I think I could have got those though. But I appreciate, and I want to point to what you're doing, as a cardiologist, and you're tired. I want to let you go, but on your podcast and on your YouTube channel, a lot of information you bring on, a lot of evidence-based medicine and a lot of things that need to be incorporated. And I think as a medicine in the United States, we just focus too much on medication. We just got to go away from those things. And I appreciate all the effort that you've done with the YouTube channel. And each week you present a really great things that are helpful for our community. I want to tell you that this is my 4th day of fasting. I feel great, right? I do this all the time, but I feel good. So I was fasting during the time when you're working. So and there's some of the things that I teach quite a bit. It's not starving myself. This is my 4th day. I feel great, and a lot of time I do that just to reset my body, and just allow me to. The only part I feel bad about is I don't sleep well when I fast. My mind races and I'm thinking a lot more. So, but few more days, 3 more days, I'm good. 7 days to go. So total,
more energy. See that? You're more energetic there.
Trying to be young, got young kids. But I want to thank you. Get some rest, please. And the information you present is valuable. I actually really want to send to a lot of my colleagues who are physicians out there, because I don't think they understand some of the things that you've seen and the value of some of the market that you have mentioned. I think those things, to me, opened my eyes quite a bit today on troponin, BNP. And then in addition, I want to share with a lot of ER doc, because that's one thing we're always like, the troponin is high. it's got to be heart attack and some kind of blockage. And what you've shown is that no, it show you a lot of information. You just got to be open and understand what is trying to tell you, what your body doing. So appreciate today, my friend, and as always, appreciate all your effort and all your hard work in the hospital, because like you said, you save lives, and let's see what we can do to help people continue that.
Thank you, Ban, for having me again. I mean, you are doing a fantastic job, and I'm glad we were able to connect, and together we will prevail. So Thanks for having me again.
Okay, thank you.